topic of today is on systemic retinoids, how we apply it to acne and the acne variants. I would kindly request you, Dr. Kiprono, to tell me about time, but I'll be very fast. Yeah. Okay. So my outline, I'm going to give the mechanisms of action, how the retinoids do work and how they are so efficacious. I'm going to do how to optimize treatment, a review of the recommendation guidelines that are up, and a summary of the adverse effects and how to approach them. And for an introduction, oral isotretinoin is also called 13-cis retinoic acid, that is the generic name, and it was first approved in 1982 for the treatment of very resistant acne. And since that time, it is still the gold standard for difficult to treat acne and its variants. Now, when systemic retinoids are given for the right time and for the right dose, 70% of the patients report cure or very prolonged remissions. And for those patients, 90% will have gotten some improvement. And most of the literature say that the patients who are given systemic retinoids for the right time and the dose, if their acne does occur in future, it will be a different type. It will be milder and easier to control. Now, from the beginning, when we started giving the isotretinoin, the doses have changed. We used to give high doses for a short time or for a long time. And we used to start using it very early in the disease, but now we are using lesser doses. We are even using some doses which are not regular on a daily basis. Evidence, because of the use of the medicine, has also told us that we don't have to do so many tests. So most of the guidelines, they have reduced the laboratory evaluations. What has become very prominent is the pregnancy-associated safeguards. And all the people who normally make these systemic retinoids, the prescribers, the pharmacists, they have a commitment that there is no pregnancy that is supposed to be exposed to a systemic retinoid. That is like the gospel, that there is no pregnancy that should be exposed to a systemic retinoid. Now, this drug, it intrigued me, and I decided to do some history about it. And it was first discovered in the 1960s at the Roche laboratories, and they used to treat it for cutaneous tumors, like mycosis fungoides, very extensive Kaposi sarcoma. They used to try it for those tumors that there's nothing that you can do to the patient. And because there's nothing you can offer, then they used to offer that. Around 1975, that's the time it was started. Some dermatologists started using it in severe skin conditions, and they actually started using it in lamella ecdysis. These are still very difficult conditions. They have no treatment. So you can as well try to give the new molecules and see whether they are going to make a difference. And in 1982, it was approved for severe acne that was not responding to treatment, still very severe disease. So that one, and in 1982, that's the time the isotretinoin was classified as category X drug in pregnancy rating because it was causing some side effects on the unborn children. And in 1984, they put it a black label box. That means it will cause some fetal abnormalities. Now, in 1998, research associated isotretinoin with depression. And this was put as a caution to the clinicians who are prescribing it, so that if you know someone has a psychological problem, if you know they have a CNS problem, their depression, then you don't give them to them. You don't give it to that category of patients. In 2000, the manufacturers now decided actually to associate completely that this drug causes side effects in the unborn babies. In 2001, the first medical guide came up. It was in plain language, And it was to be given to the users, to the pharmacists, to the clinicians, and to the manufacturers, so that there is still no pregnancy which was supposed to be exposed to isotretinoin because of the side effects. And in 2002, now their patency expired, and that is why the companies which we have even in Kenya got permission to start making the generic isotretinoin. In 2005, in the US, they developed the iPledge system. This is an online program where any woman who is in the childbearing age, once you start giving them isotretinoin, they are registered so that you can be feeding there the monthly test to show that the pregnancy is negative. You put the RFTs there, you put the UEs, all the tests that were supposed to be done, so that we can see if the patient is suffering from any side effects. And of course, if the patient gets pregnant, then the termination is done and you still put it in the system. And if they decide to pull through with the pregnancy, then the side effects are recorded in the system. And this iPledge has come to be updated often. Every time there is something new they have discovered in a practice, it is updated. And the latest update was in 2018. So what is the mechanism of action? Isotretinoin works on all the etiological stages of acne, as we have seen from the other speakers, and I'm not going to go through there. It reduces the sebum production, it is anti-comedogenic, it reduces the P acnes, and it is anti-inflammatory. What are the indications? It is the best drug for nodular acne, which occurs in adolescents and adults. It can also be given in moderate acne, which is not responding to normal treatment. It can also be used to reduce scarring, like the photo we were shown there by Dr. Kahendo. That patient can be given just because you don't want, because the scars have already formed, but you want to reduce the amount of scarring. So when you are giving it, what are the cautions and the contraindications? Mental illness like depression, you really have to exclude, and it has to be excluded in both the patient and the family history. In the next nuclear family, there should not be depression and the like. If a patient is pregnant, they are thinking of getting pregnant or they are breastfeeding, then they should not be exposed to isotretinoin. And if they have liver disease, kidney disease, then you have to evaluate. If they have high cholesterol levels at the beginning, you really have to lower the cholesterol levels before you start isotretinoin. If they also have high levels of vitamin A, now here it's difficult because we don't ask for this vitamin. Unless you give the patient and they start getting very severe headaches, then you can check their vitamin A levels. If the patient has ulcerative colitis, they have Crohn's disease, these are the inflammatory bowel diseases, then it is better avoided. If a patient is diabetic, they are not supposed to be given isotretinoin because it has been found to derange the sugar control by insulin. Now, when you start a patient on isotretinoin, they have common side effects. These are side effects which occur on almost every patient. And the occurrence is 1 in 10. Dry eyes, dry throat, dry nose, they have headache, they can have general aches, they can have muscle pain, joint pains, but they are not significant. They don't stop the patient from going to work or doing their own functions. They don't make them like unable to swallow food. So they are common and they are not severe. And how do you cope? Now, if a patient is on isotretinoin, they are not supposed to undergo any skin procedures like waxing, dermabrasion, doing laser, and they have to be off these procedures during the treatment and 6 months after. If they have dry lips, they have a dry skin, then they moisturize, they can do a lip balm, and to do as often as possible. They have dry eyes, you have to put them on eye drops. If they have a dry mouth, they can chew, you can give them sweets, and you can encourage them to take a lot of fluids. The same thing goes if they have a dry nose, they can do liquid paraffin drops. Most of them will have photosensitivity. They're supposed to be on a sunscreen, number 30 minimum. Now, if they have aches, they have mild headache, they may have joint pains, muscles, you can put them on paracetamol and not alter the dose. But if the symptoms are severe, they are preventing them from doing their normal duties, then you have to withdraw the medicine. Now, what are the serious side effects of isotretinoin? The serious side effects are few. They happen in lesser people, and they happen in like 1 in 1,000 people. Now, as we said in the contraindications, anxiety, aggression, if someone is depressed, if they have suicidal thoughts, and this also has 2 coins because the disease, the way it is severe, and it is making someone have facial deformities, and they are making them not lead a normal life. Their quality of life index, the quality of life index is really affected. These patients can actually get these signs because of the disease, other than when you put them on medication. So sometimes you have to wait and see. If someone has very severe acne, they can't go to work. That someone is already having very bad thoughts. And you haven't given them the disease. So you have to weigh as a doctor, what should you do? Should you then treat them and make everybody in the family know that they have a risk of getting that? The others are pancreatitis, diarrhea, and these are all the side effects. And if they get, for these ones, you have to stop the medicine. What is the dosing? The general rule, you start at 0.5 milligrams per kg and you up the dose slowly. Previously, we used to say you give a maximum of 120 milligrams per kg for the duration of treatment. But now we are saying you up the dose until you get a clearance of 90% of the lesions. Once the 90% is resolved, that is the dose you stay on for about 4 to 8 weeks before you start coming down. And the medicine is better taken after a meal. For the current guidelines, men are not affected. Even if the wife is pregnant or they are trying to conceive, they are not affected. Tachyphylaxis has not been reported. This is resistance. Resistance has not been reported. Drug interactions, it is a vitamin A analog, so you cannot give any other supplement which has vitamin A. We have doxycyclines, and then we have other acne medicines. Like if a patient is on a systemic retinoid and you put them on a topical retinoid, they can suffer from more side effects. So you have to be careful when you are using other medicines which are in the same group. So we have the European guidelines. These ones are the ones we normally follow in Kenya because we are more European oriented. And these guidelines came just to harmonize and to make everybody prescribe the generic medicine and also be aware of the side effects and how to handle them. And let me go through the new guidelines. What do they say? The starting dose is 0.5 milligrams per kg. Now, they have said that isotretinoin is never ever going to be a first-line treatment. Even if the patient has very severe acne, you have to take them through the tetracyclines, the erythromycins, the steroids, other things before you take them to isotretinoin. It's not a first-line treatment, even in severe acne. It is not indicated for those who are less than 12 years. And then now the blood tests, you do them at time 0, you repeat after 3 months, and if you're going to go to 6 months, then you repeat even after treatment. And of course, you have to stop all skin procedures. Pregnancy prevention program, this one has to go on in all countries, and we do that also. Now, what about isotretinoin in patients who have systemic diseases? What are you supposed to do if a patient has Crohn's disease, if they have diabetes, if they have epilepsy, and they have very severe acne? Should you give them? So what they did in these guidelines, they separated the conditions into 3. And these lists are not exhaustive. But what they say in protocol 1, these are diseases which are common in the setup. Because if a disease is common, that means there are many patients who have been given isotretinoin and nothing much has happened to the primary condition. So for this, for the standard regime, you give them the normal doses. Even if we had put diabetes in the other place, you just have to be more cautious, but they can actually start the normal dose of isotretinoin. Now, protocol B are those conditions which are a bit rare. That means those patients have not been exposed a lot to isotretinoin. So even in research, in evidence-based, the doctors who are using, they haven't used much. So like in chronic renal failure patients on dialysis, those are a bit of rare conditions. And you may assume not many of them have been put on isotretinoin. So for these ones, you give them half the dose. Instead of starting at 0.5, you're going to start them at 0.25 milligrams per kg until they respond. Now, category C are those conditions which are very rare. Yeah, that means those patients, in all the evidence that has been based on practice, they have not been put on isotretinoin and there is no evidence what happens. So for those ones, you're supposed to give them 20 milligrams of isotretinoin once a week. Then you see the response. That is for protocol C. Now, what can necessitate you to use isotretinoin early are those conditions, family history, if the acne is below 12 years, and as stated there. So who are the patients who respond slowly? If the macrocomedones are more than 70%, if they severe acne, if they have a hormonal issue, if they have poor absorption. And this one I found interesting. If a patient does not get cheilitis, the lips are not inflamed, that patient is not absorbing isotretinoin. But if they have very severe cheilitis, they are absorbing a lot, and that is why they are having a lot of inflammation. So if you see a patient and they come and tell me, oh, my lips are not even affected, that's a bad sign, it's not a good one. So that means they are not going to respond well. The other thing I found is about staph aureus colonization. Every ulcer you find on the face which has passed and they are deep, and they are not responding well to isotretinoin, most likely they have staph aureus secondary infection, which occurs in about 1% of the cases. You're supposed to do a pus swab, get the sensitivity, and you clear that. And of course, in the acne variants that we have been informed by Dr. Kahedo, they also are poor responders. So when they respond poorly, cancel them, make sure they are adhering. Then you can add an antibiotic because of the staph aureus. You can add a steroid because maybe there is a lot of inflammation. If they're not getting cheilitis, then you have to up the dose and then doing the skin swab to rule out any bacterial colonization. And those are the special variants of acne, which you know, even if you have been told not to give it as the first line treatment, once you start them on another modality, that is where you are going to head to. Like acne fulminants, you have to start them on a steroid with isotretinoin. Cogrobata, they don't need a steroid. Then there are others which are very variable treatments, but it is worth to try isotretinoin on these patients. And those are the areas of new research. We need to find out, or we need to get prospective studies to determine if there is a causal link between isotretinoin and depression. Are the patients getting depressed because of the isotretinoin, or is it because of the primary problem? We also need long-term prospective studies to determine if there's a causal link between isotretinoin and inflammatory bowel disease. The patient who won in the US because they took isotretinoin and then their ulcerative colitis got worse. So they went to court, the court listened, and because at the time that isotretinoin was being blamed for many things, they won a heavy award. But the company stayed, and many years they went back to court. And they went through the medical history of this patient. And actually the case was overturned. That is why now we are giving isotretinoin even in ulcerative colitis. And it was found that this patient had ulcerative colitis even when they were very young. So it had nothing to do with isotretinoin. And of course, we need more studies to know what is the best way of preventing pregnancy in a patient who is on isotretinoin. And is there a cumulative dose? Is there a maximum dose that we should stop at? Because that, the jury is still out. And thank you very much.